I'm very pleased to introduce this speaker. Dr. Thielke has incredible expertise and has a magnificent way of making it meaningful to a broad audience. He's a professor in the Department of Psychiatry and Behavioral Sciences and is a geriatric psychiatrist and health services researcher at the University of Washington. He conducts research about dementia medications, depression, and pain in older adults, and the use of monitoring technologies in healthcare. He's going to speak to us today on the whole person in dementia. Welcome, Dr. Thielke.
Great. Thanks a lot, Barb. It's fantastic to be here. Again, I always really look forward to speaking in this series because it's an opportunity to share what I think is really important. One of the forums for me, what matters most to me about dementia care and how we can value the whole person in dementia. And I hope to make that clear as we go along. Basically, what I'm going to be trying to convince you of is that the way to do the right thing for patients with dementia is not necessarily to focus on the science of what's going on in their brain, but rather to understand what the effects of dementia are on them and their world. And in particular, to focus on the challenges that caregivers and families face when they're dealing with people with dementia. So I'm happy to take questions along the way. I think the chat is the best way to put them, if that's all right, although I'll also watch the Q&A, but the chat might be the best approach. And just feel free to put that in and then I'll watch. And if I don't answer it right away, Barb is going to be watching that and she can remind me. And then hope to leave time at the end too. So when you learn about a topic, let's say you're learning about a disease, say like diabetes, there are certain parts of it that you need to figure out, like how you define it, what things are like it but not the same thing, what the causes are, all the different forms of diabetes, diabetes 1, diabetes 2. What tests you use for it, some epidemiology, and then the natural history. And all that stuff is important for understanding healthcare and human health. And most of it would be called, book learning. And certainly it's very important for most everything that you deal with. Like if you're going to work with people with diabetes, you want to understand what regulates blood sugar and how the pancreas works and what you can do about that and who's at risk for diabetes. This is all very important, but what I'm going to try to demonstrate is that in dementia, the challenge is not so much understanding what dementia is as understanding why it has impacts on the individual and their family. And then that is what leads you to do the right thing for the patient and their family overall. And it's a little bit less about what's going on in their brain. In fact, I would say it's kind of not important that much what's going on in their brain if you really are meeting the person where they are and you're working to understand their concept of the world and how you can help them and their loved ones deal with the challenges that they face. An extreme example of this, as I put it sometimes, is that even if you believed that dementia was caused by evil pixies or fairies or something that put a hex on somebody, you might do a better job of helping people with dementia than if you were the world expert in the neurobiology of dementia. I know that this sounds a little bit ridiculous, but I do think from my experience that what's important is remembering the individual and the effects that dementia is having and focusing less on the cells and the brain. And so that's what I'm going to try to get at. Of course, we do need to know details. So the way I'm going to focus the talk today is, first of all, to go through a little thought experiment. I hope to persuade you that what matters is not so much medical, but social. And then to go through the specific types of dementia and what they are, how they happen, kind of the book learning part of this, and then to step back again and think about how we can really help people with dementia. And I know that the rest of the series is largely focused on that theme also. So here we go. I want to start off thinking very generally to make it personal. So if you could give some thought to this question really quickly, and imagine that one of your parents starts to develop memory problems. So they can't remember if they took their pills, they've been out driving and get lost. They tell you that their neighbors are taking their things, and they're a little bit of a safety risk at leaving the stove on. So if you were in this situation, what would you do? So if anybody wants to put it in the chat, please feel free. Otherwise, I will give what I assume some of the common concerns are. If anybody wants to write an idea of what they would do in this situation. Safety is always first. Safety and safety. Yeah, exactly. So your concern now is my parent is maybe unsafe. How can I keep them safe? And I guess that's the second question also. So ask the parent what they're worried about. Talk about the concerns, worried about them hitting something, safety in all the situations, and the variations depending on the person. Right. So I think this schedule a doctor's appointment and introduce caregivers. So partly a medical workup, partly a way to keep your parent safe. So get a physical to rule out the reversible things, conversation about what's going on, stay with them. Okay, so staying with your parent. This is a great topic. If this happened to you, I think you could ask yourself, would you give up your current way of living in order to make sure your parent was okay? Would you quit your job to stay with them to supervise? And if not, how are you going to ensure that they're safe? You could ask other loved ones or friends or family to do it, or if your other parent is around, they could certainly help out. But it pushes the question of how you're going to make sure that they are okay. Driving, great point. And social services. So yes, providing support for the things that your parent would need. Oh, this is a great answer here. Built a home on place and hired help. So yeah, so sometimes I've asked this question and people say, I would definitely step in, do it myself, be there for my parent. Other times people would say, no, they're busy. I'm busy, and we need to find ways to take care of it. But that's clearly no right answer. I think what we're converging on here is that your needs are very practical in origin, trying to get someone to help take care, or as you nicely put it there, Alina, to share the load. It's putting a strain on the family, but would put a strain on you, and it forces you to take action of some kind. And the needs that we identified are primarily around safety. So how can medical care help you? I think we sort of addressed a little bit. So making sure that it's not caused by medications, doing a physical exam of some kind, working this up to make sure that you're not missing something. But really, nobody is saying what my parent needs is, some fancy procedure. So this is very different than if your parent was, say, vomiting blood, or if they were found to have some form of cancer that was treatable, in which case we would be saying, what you should be doing is finding the best medical care that can be delivered quickly, and then plan for medicine to make things better. In this case, the challenge is finding ways of finding resources that can be paid for that will help to keep your parents safe. I don't want to belabor this too much, but I do think that if you think around this situation and consider what it would mean to you, your needs would primarily be social, And you'd probably want to have a medical appointment in there to sort it out. But really, the challenges are day to day and around safety and caregiving. So let's say this goes even further, and now your parent really is not independent in their activities of daily living. They need help with the hands-on. They don't remember you. And let's say, just purely hypothetically, those siblings aren't there, and you're the only one who could care for them, which is often the case with patients that I see in my practice, where there's a spouse who's the caregiver or one child, and now you need to take care of somebody who has these needs. Again, we could think about the practical needs, but I think it's pretty clear here what you need is someone to take care of your parent, and either it can be you or you can have somebody else do it, but you can't just leave them to themselves. They now require a bunch of care. Home care would work. There's nursing facilities. We get a lot of people who are admitted to our inpatient psychiatry unit because they're in this situation and they're aggressive. But the issue really is not medical anymore at all. The issue is about finding a way to care for someone, to provide full-time or almost full-time caregiving. And again, as you point out, to Teresa, safety first. But here the issue with safety is even more extreme. So I think what we're seeing clearly is that the worse problems get with someone's cognition, the less the challenge is medical and the more the challenge is around functioning and around providing caregiving. I always think about my work at the VA and how helpful I was to patients compared to how helpful our social worker was. And the social worker could provide those resources that you were mentioning, help provide people with care, help provide caregiving support. And I could do the medical workup. As you point out, Janice, it's very important to work up medical issues, but once that was taken care of and things have progressed, the issues really are primarily social rather than medical in origin. And that's what I'm going to try to get at a little bit more as we think through what the different forms of dementia are and how you can make sure you're not missing something, but once you are sure you're not missing something, to ensure that you're dealing with the fundamental problems that people are facing. Wandering, another very important challenge, as you say, in snow country. So this is a very frequent occurrence that not only does someone need help if they stay put, but you also have to find ways of making sure they stay put. So I want to switch the gears just a little bit and have you think about a different kind of social context. So let's say we live, or you live in a place with a large extended family. Some of you may actually have this. And instead of having children who work outside the home and smaller family units, which is typical for our industrialized world, that there are people who are at home all the time, family members who can provide care for your older loved one, your parent, who needs assistance with all these things. And assume that they've got the same degree of impairments as in the second situation. If you think about this situation, what you realize is that those social challenges are no longer there in at least the same extreme, because you have people in the environment who are able to provide the sort of support that is needed. And really, the challenge that we face in the industrialized world is that we don't have this kind of close-knit, supportive, wraparound family and social and community support that is present in other parts of the world. So when you really think about why dementia is a problem, it's a problem for social and cultural reasons rather than for medical reasons. It forces older people with cognitive impairments basically to be taken care of, and that is what makes it difficult for everybody. And if those needs are no longer present, then you don't have a challenge. When I've talked to people who have lived in communities like this, they will tell me that, as people get old and show, dementia or senility, as they might call it, it's not the standard practice to take your loved one to the doctor, because it's just assumed that as people get older, they will have more needs, and that it's younger people's job to take care of the older people. So that's really fundamentally the challenge that dementia poses for our world. It's a challenge of small nuclear families where everybody is kind of on their own as they get older, and we don't have the strong kind of community and family supports that would allow people to be supported. So there's sort of my soapbox, and now we're going to jump more into the specifics of dementia, but I want to come back up to this challenge as we get through the detail, and then can focus more on what really can help people with dementia cope better. So yeah, thanks, Joy. Great point about small towns, and Alina to point out the importance of gracious and compassionate care. So we'll get to the issue of caregiving later. All right, so I want to get kind of technical now and give you some definitions of dementia. And it is important to define dementia carefully, because it really helps you to keep it separate from other medical and psychiatric problems. And I'm going to go through that in a few different ways. So this first definition is one that Sue Borson has used for a long time. It's very nice because it's succinct, and it's also important because it kind of differentiates dementia from what dementia is not. So dementia is a significant chronic loss in memory and or mental functionings that involves structural damage to the brain. So significant means that it's not just a subjective concern. It actually has functional impairments, functional consequences. We will come back to this again and again. So it's significant on the individual and the way they live. It's chronic. So it does not come on real quickly. If something comes on quickly, then you need to think about delirium instead. It goes on for a very extended period. It's a loss. So if somebody has never had a certain degree of cognitive functioning or memory, then that's not dementia. It has to be a decline. And then it involves memory and or mental functions. It's not necessarily memory to begin with. And then most importantly, for thinking about what is really involved, it involves structural damage to the brain. Neurons have died. It's different than a neurotransmitter problem. So when you appreciate that, you can see that it's not going to be something that is reversed. The second definition, where are my slides? Is sort of the same thing from a slightly different angle. So dementia here is a progressive neurodegenerative condition with functional consequences. It's not something that's present all the time because it's progressive, does not come on quickly. It's not just part of normal aging. The series covers normal aging separately, quite a different process, and it's not insignificant because it has functional consequences. But it's not necessarily memory focused. It's not necessarily just one type of dementia. You don't have to have behavioral problems. It doesn't necessarily have to be age related, but it usually is. And it's not necessarily a fatal condition. Instead, it really is a process where the neurons in the brain are deteriorating, and that has effects on the individual's functioning. DSM-5, which is the psychiatry kind of manual or Bible, has a set of criteria for dementia. They recently revised these. They got rid of the word dementia in the official title. Now it's called major neurocognitive disorder, and in parentheses, dementia. And I think that was a reasonable change because dementia has a variety of other meanings, at least in the popular communication. And so major neurocognitive disorder is a little more specific. So for you to meet DSM-5 criteria, you have to have a significant decline in domains, and those are listed down below. There have to be functional problems that interfere with independence. Once again, dementia requires functional changes. If somebody just complains of memory problems and does poorly on memory tests, but is functioning in the same way, that is not dementia. And that dementia or the symptoms are not caused by delirium or another condition. So you can see what these domains are. It's a little bit unnecessary to go over them in detail. You can see there's a variety of things, including language, ability to solve problems, and social awareness. Usually there are a variety of changes that happen simultaneously, but you only have to have one of them to meet criteria. And then the specifiers in DSM-5 are either possible or probable. So they acknowledge that it can be difficult to make a definitive diagnosis of dementia, and then with or without behavioral disturbance. So once again, you don't necessarily have to have behavioral problems to have dementia. There can be dementia without behavioral problems. And then the severity of the dementia is based on functional status. So this is, once again, the importance of functioning in diagnosing dementia and figuring out how bad it is. So great question about behavioral disturbance, equal personality change. No, behavioral disturbance is actually agitation or unpleasant or unacceptable behaviors, including repetitive behaviors, whereas personality changes are people acting in a different way than they would have. And certainly those two can overlap, but those are fundamentally different things. And oftentimes people have personality changes without behavioral disturbance per se. Great question. All right, so I mentioned delirium a few times, and I don't know if Emily Trichu showed this slide last week, but it's a nice reminder of the fact that dementia overlaps in several important ways with two other common conditions in older age, which are delirium and depression. The challenge is that if you just see someone as a snapshot, just evaluate them for 5 minutes, they can seem like they might have any one of these based on the same findings. So if somebody's a little bit confused, can't do things don't seem right, and their loved ones are worried, it can be any one of these. And you have to dig deeper to sort out what's really going on. So delirium is also known as acute brain failure. It's where your brain goes offline as a result of a medical cause. Delirium is a medical problem. The most common cause in older adults is medication side effects, followed by infections. But many other causes, including metabolic abnormalities, can cause people to become delirious. It comes on quickly, it waxes and wanes, and the main problem is with attention. But if you see someone who is delirious and you don't know how long it's been going on, you might assume that they have dementia, which is why it's important to ascertain how long symptoms have been present. Dementia involves specific problems in certain domains rather than problems with general confusion or attention. It's slow onset and chronic, as I mentioned before, and the key to dementia is functional decline. Depression, you'd think might not look like these, but really it can masquerade as them because people who are depressed stop caring and stop carrying out activities. But if they're asked in specific ways, they will be able to carry out cognitive tasks. I'll get a little bit more to depression a little bit later. But if somebody is severely depressed, it can give the impression that they are having significant cognitive problems. All right, so let's talk very generally about dementia and then go through the subtypes of dementia. As I mentioned before, dementia is not necessarily age-related, but the single biggest risk factor for dementia is age. It's very rare in people before midlife. The rate starts going up at about age 65, and then it goes up exponentially after that. So you can see older than 80, about 30% total of people have it, and that is because the older you get, the more likely it is. This is research from 5 different locations in the United States and Europe, where they looked at the prevalence of dementia by age. And it's pretty obvious that the older you get, the more likely dementia is. And by the time you hit 90, the prevalence is quite high. So the single biggest risk factor for dementia is age. And we'll talk a little bit more about what that means. Nobody has quite sorted out what the changes are that start happening in your body at about age 65 to explain why the rate would go up so much and be such a steady increase. So there are 4 main types of dementia that we'll cover. The most common is Alzheimer's, and then vascular. Lewy bodies, not that uncommon, but not all that common. Frontotemporal dementia is relatively rare, but needs attention. And then reversible dementias are a whole separate category that we can kind of cover very quickly. The important thing to remember about these subtypes of dementia is that there is considerable overlap in them. It's not like you're dealing with 4 totally separate dementias. In fact, there are some studies that suggest that the most common form of dementia is mixed Alzheimer's and vascular dementia, rather than being pure Alzheimer's dementia. And Lewy body and Alzheimer's dementias overlap considerably also. Even the other forms that are known as reversible overlap often with Alzheimer's disease. So you should not be thinking about these as being totally separate categories. Instead, often you get findings across different types. And unfortunately, the only way to know for sure is oftentimes by a post-mortem brain autopsy, which is not ideal as the way to figure out what's going on. But also, as I'll try to point out, you don't necessarily need to know with a huge amount of detail what subtype you're dealing with in order to do the right thing for the patient. So Alzheimer's disease gets a lot of press. You could spend hours and hours talking about the nuances of Alzheimer's, and I'm going to try to give a very big overview. The history is interesting. This on the left, that's Alois Alzheimer, the one who first identified this as an entity. And on the top right is his first patient, August Dieter, who was in a hospital where most of the people were being treated for what was known as paralytic dementia, which in those days was the most common cause of cognitive problems. And what most people had was neurosyphilis, which then was subject to cure about 20 years after Alzheimer's work. And it's funny to think that neurosyphilis is almost never found these days, whereas Alzheimer's disease was very rarely found 100 years ago. So that's completely shifted. But what Alzheimer did, which is noteworthy and why his name is attached to this, is he noticed that this patient, August Dieter, had very different clinical symptoms than the other patients in the unit. Her types of delusions were different. She had more short-term memory deficits and more executive functioning deficits, and she didn't show other symptoms of neurosyphilis. So Alzheimer reasoned that she must be having a different type of process, and he carried out a biopsy or autopsy on her brain, and he found these things that he drew. At the time, he didn't really know what they were, but he identified them as these two separate constructs that we know as plaques and tangles. It's interesting because we have so much Alzheimer's disease now that you kind of, if you found a group of older people somewhere, you would easily identify a lot of patients with the same type of problems and be able to categorize them as fitting the same category. But for Alzheimer, it was rare enough that he picked up on something unusual, and that is why we still use his name for this condition. It was kind of a brilliant insight that there was something different going on. So this on better resolution is what he saw. He saw that there were these things called amyloid plaques that were outside of the cells, and then things called tangles that were inside the cell. And these are the hallmark findings of Alzheimer's. They occur primarily in the outer layers of the cortex of the brain, and they accumulate and worsen with the disease. At least that's the very basic understanding of what's going on. Unfortunately, when you break down the biological process, it kind of stops making very good sense about exactly where Alzheimer's comes from. We know a lot of these details. This is about how you go from the amyloid precursor protein APP to the amyloid sheets that then aggregate and turn into plaques. And then as the plaques form, you get things that the tangles form, and those are made of a protein called tau. And you can see on the slide that there are factors that increase or decrease the activation of all these steps. And you'd think, well, since we know this much, it would be really easy to intervene at any of the steps or to prevent the amyloid precursor protein from forming. And that has been the subject of 100 years of work. Unfortunately, basically all of the efforts at acting at these steps or counteracting them have not succeeded. Some of them have increased the progression of Alzheimer's. Others of them have had very severe side effects. And even the treatments that have made it to approval don't cure the underlying disease. So there's a lot of steps, but we really don't understand fundamentally what is going on with Alzheimer's as the root cause. Just as an example, the amount of amyloid burden, the plaque burden, is not strongly correlated with the degree of cognitive impairment. The tau level is correlated with the amount of impairment, but if you look at the brains of all 90-year-olds, there are very frequent, in fact, almost universal tangles, but that does not differentiate out the people who have Alzheimer's disease or not. So ultimately, what you get to is that all of these changes result in dying neurons. There's some thought also that the dying neurons are what causes the tangles to accumulate, but that's kind of neither here nor there. Ultimately, what happens is the neurons in the brain have died. Lots and lots of neurons have died. If you have 10 billion neurons in your brain, you can lose millions and millions of them and still have enough for basic functioning. But over the years, that accumulates and you get lots and lots of tissue death. On the top, that's a picture of a thinned out Alzheimer's brain. Especially on the lower sections, you can see that there's extreme thinning, especially in the areas of the hippocampus and the inferior temporal lobe. The CAT scan on the bottom left is a brain with Alzheimer's compared to a normal brain on the right. And you can see how the brain on the right is plump, fills all the way to the edge of the skull, the inside part of the skull. The bottom part of the brain is not thin, whereas the brain with Alzheimer's, all of the parts of the brain have shrunk. Unfortunately, the imaging is not precise enough to be able to diagnose Alzheimer's from imaging because there are a lot of other reasons why people have shrunken brains as they get older, including normal aging. And there are some people who have Alzheimer's who have a lot of neuron death and plaques and tangles, but don't have significant changes on their gross anatomy. So this is more for illustration rather than to make you think that you can pick out people with Alzheimer's from imaging. The other important thing about this, about neuron death, is that it demonstrates that the problem in Alzheimer's is not neurotransmitters. In all the other psychiatric conditions, we assume that the problem is that people have levels of the brain chemicals like serotonin, dopamine, norepinephrine that are off, and then we can use medications to intervene and change those levels and restore things to normal. That's obviously an overly simplistic model, but it just does not apply to dementia because in dementia, the neurons are dying. And unless we had some kind of treatment that could keep the neurons alive or bring them back to life, which we don't now, then we're really not going to fix the problem with chemicals. All right, so back to Alzheimer's disease. Alzheimer's involves a memory problem plus other deficits. The technical names that you may have heard are aphasia, which is problems with speech, apraxia, which is carrying out coordinated motor activities, agnosia, which is challenges with recognizing people or things, and then executive dysfunction, which is problems carrying out complex tasks like balancing a checkbook. And then there are functional problems. Just once again, a reminder that there has to be functional decline to have a diagnosis of any form of dementia. And then importantly for diagnosing Alzheimer's, there's not another cause. So if we would go back to the original issue of what you'd want for medical care, you would want to rule out the other causes of things like this, and we'll get to some of them. But if you think through it, there's really not that many conditions that cause you to lose your memory and functioning over an extended period. And so even though it's important to rule out other causes, it's not like you have to go through a huge extensive list or a giant workup in order to rule out the other possible causes of dementia. As I mentioned, dementia of the Alzheimer's type is a slow and steady decline that lasts years. Early on, people tend to have loss of insight. So when you ask them how they are, they'll say, I'm fine, don't have any problems. Oftentimes, there's a late presentation for medical care when people have started to have this decline. I think on average, the time between family noticing symptoms and going for medical appointment is about 2 years. So it's very different than a loved one, vomiting blood, where you'd want to get attention right away. People kind of fill in for the deficits and help support the individual in their environment. But it's not like people rush to the doctor when they start to have some of these challenges. In Alzheimer's, pretty much every day is about the same. There's not a lot of waxing and waning. And overall, as things get worse, eventually people die in about 8 to 10 years. And typically it's from other medical causes. Even though if dementia goes on long enough, the brain does completely fail. Most people die from other causes. I want to go through quickly the different phases of Alzheimer's. And then to remind you at the end that there's no guarantee about progression, but this is a very rough estimate, and it usually fits with about how people change. So For 2 to 3 years, people have memory, language, and problem-solving difficulties. They may have trouble making choices in day-to-day life or forget to do things. And this is the time when people often help fill in, going over once in a while, checking on somebody once a day is enough to help them get by. And people often don't present for care. At this time, that's when you want to make sure there's not another cause of the problem. Delirium, we talked about before, is quite common. You want to make sure there's not medication side effects or other unmanaged conditions. Sleep apnea can be a major factor in cognition in later life. So if somebody has sleep apnea and they get treated with the CPAP, a lot of times their cognition improves a lot. Sensory deficits, such as problems with hearing or vision, can have a huge effect on functioning and ability to communicate, which can appear to be similar to cognitive deficits. And then Dr. Chichu, Emily, who talked last week, and I have done work around the effects of PTSD on cognition in older adults, and found that there's a lot of folks who have PTSD who have problems with memory and functioning, but who do not have dementia. And when we boil it all down, it's clear that it's the PTSD that's interfering with their ability to be present in the here and now. So not a huge list. The most important one is really delirium, to make sure that the individual is not having other factors that are worsening their ability to think clearly. So the further along Alzheimer's gets, the more clearly it is a cognitive deficit, and kind of the less important it is to rule things out, because with delirium, things wax and wane. With these other causes, they should become apparent over time. And most of these other things that I talked about are not progressive. So if somebody's having a progressive cognitive decline over a period of years, that's pretty much dementia until proven otherwise. In the middle stage, people have more problems with producing speech. They have more functional problems. And this is the stage where psychiatric problems and behavioral problems, such as being paranoid, can appear. After about 6 to 10 years, the condition usually worsens to the point that people cannot communicate clearly. They're not able to take care of simple activities of daily living. They may have unexplained or unprovoked behavioral problems. I'll point out that the behavioral problems often happen episodically. So if somebody's getting agitated in advanced dementia, it's not necessarily that they're going to get more and more agitated. It's kind of a phase. And then very late into the disease, people eventually have a failure of more basic bodily symptoms, like muscle rigidity and problems with walking or swallowing. And if those progress even further, they can lead to death. But usually, as I mentioned, people die of other causes. I want to get back to the fact that even though these rough categories fit, the Alzheimer's Association has this very useful saying that I used to think was a little too cutesy, but I think really applies. It's when you've seen one case of Alzheimer's, you've only seen one case. Everybody is different. There are some people who maintain their personalities almost exactly through the disease. Other people who were very friendly and outgoing become nasty and introverted, or vice versa. Some people have really well-maintained language. So you don't want to make assumptions about what is going to happen. And that is hard because you can't tell people what is going to be the next step in Alzheimer's. But as you're working with people with Alzheimer's, I encourage you to remember this and to really think about where the person is at that time and what you can do for them to deal with the challenges that they are facing, rather than to make an assumption about whether they're going to get more or less behavioral problems and at what stage the disease is going to progress. All right, a real quick note about the genetic basis of Alzheimer's. There's an important distinction between early onset dementia, which is before age 60. That form of dementia is more likely to have a genetic basis or to be familial. So it runs in families, whereas the dementia that happens after age 70, which is much more common, is known as sporadic dementia. So if you have a relative with sporadic dementia, your risk is increased by maybe 15% or so, but it's certainly not a guarantee. So if one of your parents had dementia, your grandparent, aunt, uncle, even a sibling, you don't need to think, therefore I'm going to get dementia, especially if they were older when they developed symptoms. There are some genes like apolipoprotein E4 that increase risk, but that's certainly not a guarantee. And when you really think about what happens in dementia, it's probably just an accumulation of kind of random changes that happen in the brain during aging. And it's kind of like losing a game of bad luck bingo. That just as these things accumulate, you end up with a certain connection between them at the cellular level, and that causes this process that then is not reversible. That is a little bit liberating because we can tell people that it's not like they did something to cause dementia. And also it helps to reassure people that if they have later onset dementia, that their kids are not doomed to get it. So the question that I brought up before about Alzheimer's and why it was hard for him to find people with dementia, but it's pretty common now. It would make you ask, like, why do we have so much more Alzheimer's now? And the answer is really simple. It's just people live longer. So if you remember that graph about how common Alzheimer's was in the different groups, it's down at the bottom there also in a slightly different form. Before age 60, it's incredibly rare. After age 80, it's quite common. And so if people are dying before age 70, you're not going to get much dementia. And the top graph shows that every generation since about 1900, people have lived about 10 years longer. So that's why we just have much more dementia. So great question about COVID and long COVID. I think that the jury is still out about that. There is some early evidence that COVID maybe hastens the onset of dementia in people who are prone to it. Unclear if it would actually be a cause. And then Janice, great question about delayed or prevented. I'll get to that in a minute. But unfortunately, I think that the answer is that there are no guarantees. And I'll try to convince you of that. All right, so that was Alzheimer's. At the end, if you have questions about that, we can certainly come back to that. The question about head trauma, great question. I will answer that when we're talking about risk factors and causation. Don't let me forget that, because there's a new paper that was had an unexpected finding. So vascular dementia, you may have heard this. This is it's different than strokes. That's what I encourage you to remember. Vascular dementia is different than strokes. Instead, it's the small blood vessels in the brain that no longer get enough blood to the outsides of the brain or all the parts of the brain. But it's different than people who have certain areas of the brain that are clotted off. Clinically, it looks very similar to Alzheimer's disease. And as I mentioned before, the combination of vascular dementia and Alzheimer's dementia is more common than either of them alone. There are known risk factors for vascular dementia, in particular high blood pressure, as well as other things that clot off your arteries, like having diabetes that's poorly managed or high cholesterol or other forms of blood vessel disease. It's a little bit, it can be identified partly on neuroimaging, but our tests really are not perfect for identifying vascular dementia. So unfortunately, it's not one that you could go out and screen people and tell them who is at risk. I'll just show the picture here. So this is what the common finding, these white things are known as periventricular white matter hyperintensities. And they're different than strokes. A stroke is more of a specific location, and these are more diffuse. The challenge is that if you have 100 people who are 80 years old, you will see these on a lot of the images, and a lot of those people will not have vascular dementia or any dementia. So it's kind of it's a non-specific finding. Here's the mystery of vascular dementia that I've spent a lot of time thinking about, and I just can't figure it out. Even though there's risk factors for vascular dementia, once the decline starts and people meet criteria for dementia, even if you fix their blood pressure, fix their cholesterol, fix their blood sugars, the cognitive and functional problems still continue pretty much at about the same rate as they do for Alzheimer's. And I don't know why this would be. I think ultimately vascular dementia involves some kind of fundamental change at the chemical, cell level, and it just is a railroad that keeps going on its own. And even though you're addressing the risk factors, you're no longer preventing worsening. So that is the key challenge, is that once the problem starts, it cannot be addressed easily. All right, so this is just a quick note about a study they did on nuns. If you're interested in the topic, I'd recommend looking up the nun study. It basically demonstrated through a group of nuns who agreed to have brain autopsies after they died, that the ones who had clinical symptoms were much more likely to have vascular changes than pure Alzheimer's pathology. So probably vascular disease and Alzheimer's disease overlap fundamentally, even though there may be different findings on imaging, and that's why they are so similar clinically. All right, Lewy body dementia is a different form. It's got different findings than the plaques and tangles. They're called Lewy bodies. These little accumulations, they're made of something called alpha-synuclein. They're in different locations of the brain. They're both the deeper brain structures and the surface, which explains why the Lewy body disease has different findings. It's relatively common, but often overlaps with Alzheimer's, so it often goes unrecognized in that way. The hallmark findings of Lewy bodies are like Parkinson's disease. So if you've seen people with Parkinson's, people with Lewy body dementia have similar findings. Their posture is stooped over, their gait is shuffling. There's bradykinesia, which is slow movements. If you move their arm, it will have a catch. And then there's something called masked facies, which is the appearance of like wearing a mask, not showing facial expressions. Lewy bodies also often have Lewy body dementia has visual hallucinations, which are quite uncommon in other forms of psychiatric disease. They're often reassuring or just kind of unusual things, like seeing a ball bouncing down the street or an unusual animal, but it's not like a freaky kind of drug-induced hallucination. There's waxing and waning in Lewy body dementia, so one day can be better, the next day worse. And oftentimes the memory problems happen after these other symptoms like the Parkinsonism. So the most important reason for identifying Lewy body dementia is that these patients are extremely sensitive in a bad way to antipsychotic drugs, and you want to be very cautious about using those. Sometimes people will be given an antipsychotic drug and get a lot worse, and that's when we really think about Lewy body dementia as being the cause. Frontotemporal dementia, as I mentioned, is a rare form of dementia, maybe 1% of all dementias. It's a separate type of process that involves a specific localized degeneration. The frontal parts of the brain actually start deteriorating, usually one side or the other. If you remember what the frontal parts of the brain do, they're kind of your personality and social judgment. So there was that guy Phineas Gage, who was a railroad worker who had his frontal lobe destroyed in an accident, and he had severe personality changes. This is the same kind of thing on a slower basis. Eventually, there are memory, cognitive, and functional problems, but the early stages oftentimes involve just personality change or bad social judgment. It tends to be much more genetically based than Alzheimer's or vascular dementia, and the age of onset is considerably younger, like 40s to 50s instead of 60s, 70s, 80s, and beyond. This is a case of a classic frontotemporal dementia. On the left, you can see that's normal brain tissue in the occipital lobes, and then the parietal lobe and temporal lobe look okay, but the frontal lobe on the right is clearly very, very atrophied. And eventually the progression goes from the front to the back of the brain, and you get more of a picture like advanced dementia, but initially it is the frontal lobes. So real quickly on the reversible dementias. This is an extensive list. You don't need to memorize this in any way. These are the conditions that are generally thought of as being masqueraders of dementia that you would want to rule out. You can tell most of them are pretty rare, and all of them can be ruled out pretty quickly through a simple medical test. You know, in the old days when they didn't have labs that could be carried out, some of these might go missed for a long time, but now you kind of could not set foot in a hospital and get a workup in an emergency room without most of these being identified, at least enough. You know, there's something wrong here on your blood tests that we need to do further workup. So they're not things that often go on for a long time, and then you're like, oh my gosh, you know, for the last 5 years, that's been the cause of the cognitive problem. So just important to know that there are some medical conditions that have cognitive effects, but don't think that there are a bunch of medical things that look just like dementia for the long term. On the bottom right, this is just for fun. This is a sign in Wilson's disease, which is known as the face of the giant panda. If you look right in the middle of the brain, it sure looks like a panda bear. And that's actually copper deposition in the brain, which is what happens in Wilson's disease. All right, so what do you do in figuring out if somebody's, you know, what the source of their cognitive problems is? Basically, the key to diagnosing dementia is to get a good history. The patient often won't tell you, so you have to talk to one of their loved ones who can tell you if there has been a slow, steady decline over time or how long symptoms have gone on for. You want to make sure that you're not missing something physical, rule out delirium, usually by a basic set of labs, and then just think quickly about those reversible causes. So if there's abnormal findings, like if there's some neurologic finding that is unexplained or some lab abnormality, you'd want to do more and more workup. But if somebody's 80 years old, otherwise medically stable, and they've had a slow, steady decline in functioning and cognition for 4 years, that's less of a reason to do extensive workup. Those are the labs that are listed that are the basic psychiatric admission labs. Frankly, I've never found any abnormalities in these that changed what we did with dementia. So even though we look for them, it's not like you suddenly get a brilliant diagnosis and explain the person's functional problems because of a B12 deficiency or low thyroid. They're good to know about, but they're not something that would greatly impact management. And then, despite the fact that we have lots of fancy CAT scans and MRI machines, the neuroimaging that goes into dementia workup actually does not add all that much to the clinical management. So those are not routinely indicated. But certainly if you have a specific thing you're worried about, like if somebody has a neurologic symptom, you would want to make sure you get neuroimaging. This is the mini mental. That's not really used anymore. Now it's probably more the MoCA. And that is a standard test. And it's good to do some basic cognitive assessment. The important thing about this test is that it depends on both age and education. So the norms as you get older drop. You can see that in the bottom right graph. The lower education level, the lower the expected score is. So these are normal scores. So you can see if somebody's 80 years old and has only 5 to 8 years of education, 25 would be a good score. Whereas if they're younger and have higher education, they would have to get 30 out of 30. I should mention this is out of 30 points. And if somebody has dementia, they're dropping about 3 points per year on average. And you can do the math and realize that you don't have to go that many years until you're well below any of these norms. But if somebody has low education and they're older, it's a little harder to tell if that's to be expected or if it's due to a change over time. And the math nicely fits also because 3 points per year, 30-point scale, that's about 10 years until you get to 0. And that's often how I remember the 3 point per year is that it's 30 divided by 10. There's another great, better way to do a quick memory assessment than mini mental or MoCA. It's called the mini cog. Was developed here at the University of Washington. It's worth practicing this to have it in your back pocket if you ever want to do a quick assessment. It takes maybe 2 minutes. What you do is you get a piece of paper and a pencil and then ask the patient to remember three objects. Apple, table, penny is a good one. And then have them repeat those to you. And if they can't repeat the 3 items right away, they fail. That's basically a 0. But they should be able to repeat them. Yeah, sometimes it takes a couple tries. So they tell you apple, table, penny. There's no scoring for that. And then you ask them to draw a clock. And so they draw the clock face and then put the numbers on it and then make the time be 11:10. And then you ask them the 3 items again. So if the clock is worth 0 or 2, if there's no errors, then it's 2. If there's any errors, you give a 0. You don't get partial credit. And then you get 1 point per item. So the top score you could get is a 5 and the lowest score is 0. So if somebody gets a 3, 4, or 5, then technically that's a negative screen. That means their cognition is decent enough. If it's a 3, you want to look into it. If it's a 4, you're less worried. But definitely if they get a 0, 1, or 2, that's reason to do more workup. So if you work in settings where cognition is an issue, I'd encourage you to try this out and just be ready to do it. And you really can very efficiently assess people's cognitive status. All right, I want to get to the question of prevention. And unfortunately, the news is still kind of bad here. This is a NIH consensus report where they looked at preventing Alzheimer's disease. This is their conclusion, that even though there's a lot of factors like heart problems, cardiovascular disease, high blood pressure that are associated with risk of Alzheimer's disease, it has yet to be demonstrated that acting on those, like by a specific medication, will reduce people's risk of later developing Alzheimer's. So obviously health maintenance is important, but it's not like if at age 50 you take a group of people and you say, we're going to manage your blood pressure better, and the other people you just leave them alone. The people that you take action on with especially drugs are not demonstrated to have a lower rate of Alzheimer's. So kind of a bummer about prevention. And the other way to frame it is if you look at some of the people who got dementia, like this is Ronald Reagan and Margaret Thatcher, their politics are maybe a little questionable, but they were super highly accomplished, very smart, very healthy people. Both got dementia. They ended up being pretty bad. This is Claude Shannon, who's the inventor of the modern computer, incredibly fit guy, super active physically and mentally. He got dementia. And when I think about my patients at the VA, I had guys who were running marathons in their 70s and were lifelong vegetarians, never smoked or drank anything, and they ended up getting dementia. Whereas there were people who had terrible health for most of their lives, drank and smoked a lot, had bad cholesterol, were obese, never exercised, and they did not get dementia. So certainly that doesn't explain the overall correlations, and there certainly is benefit in better health in general, but in terms of specific things that can be done to prevent dementia, we really don't have evidence around that. The issue of head trauma and dementia is a great one. There's a recent paper that came out by Paul Crane, C-R-A-N-E, where they used a couple of databases and were able to determine the association between earlier onset head injury and rate of dementia. And this was really surprising because I was taught and assumed and would hear a lot that head injury increased your risk of all forms of dementia, especially Alzheimer's. And what they found, in fact, was that there was no association with Alzheimer's risk. So having a head injury didn't seem to increase your risk of getting Alzheimer's, but it did increase the risk of Parkinson's or of Lewy body or Parkinson's related dementias. So kind of unexpected. And the rate wasn't huge, but it was a strong association. So head trauma probably increases rates of Lewy body or Parkinson's related changes, but it is not a risk factor for Alzheimer's itself. Yeah, thanks for asking that question. All right, I want to talk about screening really quickly because this is an important topic that can easily be misunderstood. It's important, on some levels to know if somebody's got dementia. And you might say, well, we should go out and look for dementia in people in the world. When people come in for an appointment, we should see if they have dementia or not. But there are unintended consequences, and I want to do the nitty-gritty of the math just to hammer it home. So this is a little blurb I found that said, here's this new test that predicts Alzheimer's. It's got 90% accuracy, and it's been validated by biomarkers, and all you need to do is give people this blood test and it'll tell you if they've got dementia or not with 90% accuracy. So 90% accuracy would mean that if you have dementia, then 90% of the time you get a positive test. That's the picture on the bottom left. If you don't have dementia, then 90% of the time you get a negative test. That's the picture on the right. And that sounds pretty good. Hey, 90%, that's an A or an A minus. But when you really run the numbers, you run into a challenge, which is that not everybody has dementia at this age group. So if you're screening 70 to 80%, and the prevalence is, say, 4% in the community sample, and then you look at the numbers of people who have dementia, who would get a positive or negative test. You can read through that if you want. What you find is that in this group, 4 people will be wrongly told they don't have dementia when they do, and 96 people will be told that they have dementia when they don't. It's probably easier to see graphically. So if this is the whole population, on the bottom left are the group with dementia, and then the positive tests are the people in the green and the yellow boxes, and the people with negative tests are in the blue and the orange boxes. What you see is that most of the positive tests are for people who don't have dementia. So if you have a negative test, you're unlikely to have dementia. The false negative rate is low. But if you have a positive test, you actually only have like a 25 or 30% risk of having dementia. So 2/3 of the people will get a false positive test. 2/3 of the people who got a positive test, it was a false positive test. And you can think about what that would mean for you to be told, oh yeah, we did this blood test and we think you have dementia, and therefore you're going to get worse over time and it's going to be a burden on your family. And then, there's no other way to prove that you don't have dementia at that point because all you did was this test. So we still don't have a gold standard for early prediction of dementia. And for that reason, dementia screening is not a good idea. just in a general population. It's much better to wait until people have problems or concerns and then to do more workup. But the idea of doing a wide scale screening test like a blood test is just not appropriate in dementia. And if you know about screening tests in kids, like in newborns, those tests are like 99.95% sensitive and specific. They have to have very, very good rates, or else you end up with this problem of false positives, and you end up telling people that they may have a condition that they actually don't. You may know that as part of the annual wellness visit through Medicare now, there is a cognitive assessment, but this is different. It's different than making a diagnosis or screening for a problem. Instead, it's a way to open up a conversation about functional and cognitive difficulties. All right, so I want to come back again to the challenge of how to take care of the whole person in dementia. And I hope that we didn't get too lost in the details. I hope I've convinced you that dementia is a problem because of the individual's functioning and the need for others to take over for them as they have functional declines. And that really leads to the next and more important question of how we can help people who have dementia. We don't have a cure. Medications can have some effect in some patients, but they are not, in fact, game changers when you look at the changes that happen in people who take medications compared to not. And really, what I hope that you will appreciate is that the way to care for people with dementia is to care for them in their world, to think about where they're coming from, to think about those 4 M's, and to think especially about the effect that dementia has on their loved ones, and especially their caregiver. So the mantra of doing a better job on a population for dementia is to care for the caregiver. And really, when I think about the good that I've done in dementia care, it really is focused on making sure that the caregiver and the whole system of support for the individual are functioning and intact and working well, rather than thinking the problem is with the patient's brain. So as you're talking to caregivers, it's important to listen and hear what their perspectives are like. Sometimes people find things easy or no big deal that you might think would be very hard. Other times people complain about things that seem like they wouldn't be that big of a deal. Caregivers oftentimes have challenges of their own. Being a caregiver is associated with depression, and it's exhausting. So you want to look into the caregiver's mental health. And then as you're thinking about how to help them, you want to focus on the quality of life of everyone. I would almost always try to convince caregivers that the key is to increase everyone's quality of life, including their own. And that if they're doing all of their time, spending all of their time taking care of their loved one, they're going to get exhausted. And relying on other people for help can make a big difference. It's funny, these were exactly the kind of comments that came up initially when I asked for your thoughts about what's going on with the loved one who has dementia and how you can deal with it. It really is focusing on the bigger picture and how to get help for caregivers and support the individual. And then there are great community supports, but if you don't access them, they won't help you. Alzheimer's Association is a great resource, and then every county has some resources. The book that I have up there is the one that I hear the most positive feedback from family members. The title kind of explains it, and I'd encourage you to have that in your repertoire, just the saying 36-hour day. So if you have a caregiver who's burned out or seems to be getting burned out, and you tell them, wow, it sounds like you're working the 36-hour day, it really can resonate and be an opportunity to discuss how they can get time for themselves. Let me really quickly address the things in the chat about prevention. So these are great points about the association between certain factors and incidence of dementia, like the Mediterranean diet. These are not controlled studies. So once again, it's a difference between association and a specific act that you could carry out. You know, obviously, if you look at any of the detail about cardiovascular health, it makes sense to manage those factors. But no one has yet carried out a study where they took a group of people and randomized them to one group or the other and were able to lower the rates of dementia onset. Which I understand that's a little bit arbitrary, but I'm mainly trying to point out that it's not like there is some treatment that we should tell everybody, do this and it will guarantee you won't get dementia, because that simply doesn't exist. All right, back to agitation. People who get dementia often get agitated. What I encourage you to do is think about why they're getting agitated rather than turning to a pill for it. Unfortunately, when I talk to the psychiatry residents, a lot of times I'll present a case of agitation in somebody with dementia and ask them what to do. And they will, say, I'd give Haldol, no, I'd give Ativan. And I have to say, no, don't you want to understand why the patient's agitated? And then, they agree, maybe you do want to do that. So when you really break down agitation, a lot of times you can address it without medications. The most common reasons for agitation in dementia are listed there. If somebody's delirious, they're kind of off the rails mentally, and their behavior may be erratic. So that can explain agitated behavior. Unmet needs are huge if someone cannot articulate them. So if they're hot, cold, thirsty, hungry, have a dirty diaper, lonely, it's a natural response to become agitated. And if you can figure out what the needs are, you can address them. So first pass is delirium. After that, really focusing on if there are any unmet needs. Conditioning means that people will continue a behavior that they get rewarded for, and they will not do one that they don't get rewarded for. So if you're sitting in a nursing home with 20 patients and one aide, and you get ignored, unless you hit somebody, you're likely to hit somebody or to keep hitting somebody to get attention. So that one's a little hard to tease out, but it can make a big difference when you think about behavior as communication, as Janice nicely put it. And then the last one is I think probably the fundamental issue that's harder to get at, which is that a lot of things that people do when they're agitated make sense from their perspective. So if you could see the world as the patient did, you would probably be doing what they do. As an example, if you're sitting there and somebody comes at you and tries to take your clothes off you, you're going to fight back. You're going to protect yourself and your personal space. If you're sitting there and it's a nurse's aide coming at you to help you get a bath, it doesn't matter because you don't understand that. So if you can think about what's going on from the patient's perspective and be very sensitive to their personal space and make sure they understand what's going on, that can make a big difference in reducing levels of agitation. And on our inpatient unit, our nurses and nurses aide and other staff are really experts at making sure that people are met where they're coming from cognitively, and that's why we almost never use restraints on our unit, and our rates of agitation really are pretty low. And then finally, this is a reminder, if antipsychotic medications are used, there's a black box warning for their use in dementia. This is drugs like olanzapine, risperidone, quetiapine, Haldol. And basically, multiple studies have shown that using these drugs in dementia roughly doubles the risk of death. So that's a big side effect, and you want to make sure that people are aware of that. So if you see prescriptions for antipsychotic treatments in dementia and you wonder about it, you might bring up this black box warning. So great question, Amy, about how to treat visual hallucinations. The challenge with visual hallucinations in Lewy body disease is that, as I mentioned, in Lewy body dementia, antipsychotics often worsen other symptoms. And frankly, the antipsychotics do not do much for visual hallucinations or for auditory hallucinations. So what we do is try to address the other factors that may be disturbing the patient. And generally, the visual hallucinations don't bother them that much if they're otherwise okay. For instance, I had a patient who would call his wife over to their window and say, like, hey, look at those interesting animals in our front yard. And there weren't any. And once in a while, he'd get upset and worry that one of the animals was going to hurt him or his wife. But if he was otherwise calm, it was just a visual hallucination. So that's a great question. And again, I'd encourage taking a behavioral strategy rather than a pill. And just to encourage you to think through the idea that having something labeled psychosis does not necessarily mean antipsychotic. Great question. So Richard, you had a question about end of life planning. Very important. That's a separate topic in the series. I know that'll be addressed. Certainly extremely important. For all of you personally, for yourselves and your families, I'd encourage filling out an advance directive. It makes it so much easier for everyone to do the right thing for you if you develop cognitive problems. The worst case scenario we have is when people don't express their wishes and then we're not sure what to do. And we likely end up doing things that they didn't want to have happen, especially around prolongation of life. And it really is tragic to see people who are at the very advanced stages of dementia and apparently suffering. And we want to do things to help them, but we're not really sure exactly what they would want. So this is my contact information. Please feel free to email or call if you have any questions around anything related to this. And thank you very much for all of your great questions and participation. I hope we were able to address most of them during the time, but if there's anything else, please bring it up now or just email me.
Dr. Thielke, I think you did a magnificent job of like navigating and moderating the chat. So thanks very much. Made my life easier. Any other questions from folks real quick? I didn't see any additional ones. You addressed the Q&A about end-of-life planning. So I guess we will see you all next week at the same time. And thank you very much, Dr. Thielke. This was just an excellent presentation. Really appreciated it. And have a wonderful evening. And I put a little link there. Enjoy the eclipse on Monday.
Great. Thanks, Barb. Good to see you. Bye-bye.
Bye-bye.
Thank you, Barbara.
Thanks.